Welcome to the webinar on Beta-D-glucan. This is a useful, relatively rapid test for the diagnosis of systemic fungal infections. And today I'm going to take you through various aspects of this testing system and the different commercial assays that are available and how to interpret the different tests. Our learning objectives are to know which fungal infections Beta-D-glucan is associated with, because there are some with high levels and others with lower levels, to understand the distinction between positive and negative predictive values and the value of this test in terms of ruling in and ruling out fungal infections using Beta-D-glucan, and to know which clinical situations are suitable for Beta-D-glucan measurement. The fungal cell wall in most fungi contains quite a lot of Beta-D-glucan. It's an essential component of this fungal cell wall for most species, with the major exception of the mucorales and some other rarer Basidiomycotus yeasts and fungi. And the release of the amount of Beta-D-glucan varies to some extent, and therefore the sensitivity varies in different clinical settings. Beta-D-glucan is composed of a mixture of glucans linked with a glucopyranosyl unit, and there are both 1,3 and 1,6 different glucans, and typically the 1 to 3 units prevail, and in particular in Aspergillus there are no 1 to 6 units actually present at all. Beta-D-glucan is a strong immunomodulator as well. It binds and activates the innate immune system primarily through attachment to the dectin-1 receptor as well as to toll-like receptor 2. It's an immunostimulant, and Beta-D-glucan therefore acts as a Th1 type of stimulant for the immune system, and to that extent it's been proposed as a vaccine adjuvant. It's also been proposed as an anti-cancer therapy. And oral Beta-D-glucan incidentally reduces cholesterol for reasons that are not entirely clear. The first research into this area was in Japan in the early 1980s. The development of the first assays for clinical use were in the early 1990s, and the first major clinical study was published by Dr. Obayashi in the Lancet in 1995. You can see in this figure the values of Beta-D-glucan measured in blood, and in the red box were all fungal infections, and the majority of these had a raised Beta-D-glucan. In the green box you can see bacteriosepsis, and for the most part the levels are quite a lot lower in bacteriosepsis. Probably some of these patients have mucosal damage and therefore are leaking a little bit of Beta-D-glucan from the gut, which I'll discuss in a minute. And the blue box are patients with chronic pulmonary aspergillosis, and you can see a few of these patients have levels that are in the same range as systemic or invasive fungal infections, but most of them are lower. So there are reasons for a positive Beta-D-glucan test in patients include invasive candidiasis and pneumocystis pneumonia. It's also positive in invasive aspergillosis, and as I mentioned, in a small proportion of patients with chronic pulmonary aspergillosis. It can be found in patients with endemic mycoses such as histoplasmosis. It's also found in some rarer fungal infections as well. One of the challenges with Beta-D-glucan is external contamination, either of the tubes or the patient. And if patients with leaky guts, particularly in the context of mucositis or severe sepsis, you can get translocation of small amounts of glucan into the blood, producing low-level or medium-level positives. One of the other challenges is that the preparation of Beta-D-glucan in the manufacturing facilities is difficult because very small amounts of external contamination can produce false positives, and some blood tubes can also produce Beta-D-glucan positives. It's important to use pipette tips that are Beta-D-glucan free. Various cloths and other materials and dust contain very high quantities of Beta-D-glucan, and for that reason it's not been so much used as a test in respiratory fluids. The serum measurements are in picograms per milliliter, which tells you something about how little there is circulating, but how valuable it is to detect it. Some dialysis membranes contain Beta-D-glucan, some surgical gauze does, and so patients immediately after major intra-abdominal surgery may have false positives or genuine positives Beta-D-glucan in the blood. Some albumin, blood and immunoglobulin infusions contain beta-D-glucan, and some foods such as seaweed contain quite large quantities of beta-D-glucan, and this can produce a true positive but a false positive with respect to fungal disease. So some patients have negative beta-D-glucans, and that reflects the fact that they don't have a fungal infection, or they may have a Mucorales infection. You can also have some patients with invasive aspergillosis, and in fact all of the systemic fungal infections, who have false negatives, and probably profound neutropenia increases the frequency of false negatives. Total parenteral nutrition and hypertriglyceridemia can render an otherwise positive test negative because of complexing or hiding of the beta-D-glucan on the assay. So in terms of strengths and weaknesses for using this assay in the clinical laboratory, the strengths are that it has a better sensitivity than blood culture for invasive candidiasis. The time to results is short, assuming that the sample is received in the laboratory rapidly and the test is run frequently. There's minimal sample handling, and indeed some platforms are semi-automated or completely automated, which makes life easy for the laboratory. It's a quantitative assay, and it has a high negative predictive value, so that invasive fungal infections can be ruled out in the vast majority of instances, and this can really aid with antifungal stewardship. The weaknesses of this assay are that it doesn't distinguish between different sorts of fungal disease. So you don't know if a patient is positive, whether it's pneumocystis pneumonia, aspergillosis or candidiasis, for example. It doesn't distinguish infection from antigenemia. And circulating antigenemia in its own way has some relevance for the patient's immune status because of the immune activation. Most of the assays require a continuous ELISA type of reading, and therefore significant equipment and electricity supply is critical, as well as a well-established laboratory for ensuring the samples don't get contaminated. Trained personnel are required to perform the test and read the results. And ideally, glucan-free tubes are required to minimize false positives, although in practice this is often addressed by having a second sample taken to confirm the first positive. You do have false positives, as I mentioned, with immunoglobulin therapy, blood products, and foods and seaweed. There's also limited value of the beta-D-glucan in terms of evaluating its response to therapy. So there are various different tests on the market. Here are some of the tests that are available, and we will show you some of these in the following videos. So there's a Fungitel assay, which is with associates of Cape Cod and originated from Japan. It's the Gagaku Corporation. There is a Fungitel G test produced by Nisu. Wako have launched their own test, which is a single assay test, and there's a photograph of the machine on the right here. This company's merged with Fujifilm. Dynamica offer a glucan assay, as does Aerobiology, and they have two different trademarks, one GenoBio and the other Beijing Gold Mountain River assays. The principle of the assay is similar to measuring LPS. The factor G is a clotting factor found in the blood of the horseshoe crab, and this, combined with the presence of glucan, causes a clotting process to occur which produces yellow compound in the assay. So it's simple, but it's complicated to deliver because of the low quantities of glucan circulating in blood. So this study, which is over 10 years old, compared different methodologies of the assays, and I won't go through this in detail because it's been somewhat superseded. But I do want you to notice that there are different ways that the tests are run in terms of whether they're kinetic, using a chromogenic or a turbodimetric endpoints, and there are different cutoff values and different durations of test. And as I say, this data needs to be updated a little bit, but it does demonstrate that there are definite differences between these tests. So overall, the G-test or Beta-D-glucan test is a nearly pan-fungal blood test for invasive fungal infections. Low quantities are circulating in the blood, so it's susceptible to external contamination. And some infections, Mucorales and other bacillomycete infections, such as cryptococcal disease, produce very little Beta-D-glucan. Now we're going to move to introduce the different assays, and the first of these is the ACC Fungitel assay.
Results from the glucan procedure are presented in the format shown here. This page shows the well filling pattern when this test was set up. This page shows us the concentrations that were used for preparing the standard curve. Here we can see the individual glucan concentrations for the patient samples that were run in this assay. Here we can see the standard curve, a very linear standard curve for the 5 concentrations of glucan that were incorporated into this assay. Using this particular glucan test, values greater than 80 picograms per mil are interpreted as positive. Glucan values of less than 60 picograms per mil are interpreted as negative results. Values from 60 to 79 picograms per mil are interpreted as indeterminate results and suggest a possible fungal infection. Additional sampling is recommended. Some final comments on the glucan test. It provides a presumptive diagnosis, but of course should be used in conjunction with other diagnostic procedures. It doesn't detect certain pathogenic fungi, for example Cryptococcus or agents of mucormycosis. One of the key features of this test, it has a very high negative predictive value. The test is easy to perform and is ideally suited to a reference laboratory dealing with a high throughput of samples.
The next assay we're going to show you is the Dynamica procedure and its interpretation.
In this video, we demonstrate how to perform Dynamica fungus 1,3-Beta-D-glucan assay, also known as BDG assay. Before starting the test, take out the BDG test kit from refrigerator and place at room temperature for 30 minutes. Start the kinetic microplate reader and preheat it at 37 degrees. To perform the test, ensure that you have all the consumables and instruments. pipette 1000 microliter and 200 microliter, vortex mixer, glucan-free transfer tube, glucan-free tips 1000 microliter and 200 microliter, tube rack, timer, and microplate reader. Step 1. Standard and control preparation. 1. Open the kit and take out one vial of standard R4, control R5, and dilute R6, respectively. 2. Take out 5 glucan-free transfer tubes and label with B, C, D, E, and TR. Note: when opening the rubber cap of the vials, do not open directly. Open it slowly and do not touch the inside of the rubber cap. Three. Add 1.5 ml dilute R6 into standard R4 and control R5 vial, respectively. Note: do not touch the inside of the rubber cap during the operation to avoid contamination. Four. Vortex the standard and control for at least 1 minute. Then label with standard A and control, respectively. 5. Add 300 microliter dilute R6 into tubes with B, C, D, and E, respectively. Note: do not touch the inside of the tube cap to avoid contamination. 6. Add 300 microliter standard A into tube B and vortex 30 seconds to make standard B. Note: do not touch the inside of the tube cap to avoid contamination. Seven. Add 300 microliter standard B into tube C and vortex 30 seconds to make standard C. 8. Make standard D and E in the same operation above. Step 2. Treatment solution preparation. 1. Take out treatment solution A, R2, and treatment solution B, R3, from the kit. Open it slowly without touching the inside of the rubber cap. 2. Calculate the needed volume of treatment solution and mix equal volume of treatment solution A and B to tube TR. Vortex 30 seconds to mix vial. Note: if the lab could not finish one kit in a short time, the treatment solution is recommended to be aliquot as below. Take 8 glucan-free tubes. Add 400 microliter treatment solution A and B into 7 tubes, respectively. Add 200 microliter treatment solution A and B into 1 tube, respectively. Vortex all tubes 30 seconds to mix vial. Store all tubes at 2 to 8 degrees. Step 3. Sample treatment. Take out the strip carefully by pushing the edge of the vial bottom. Do not touch the bottom of the vials. Put the rest of the strips back to the package. 1. Pipette 60 microliter of dilute R6 into 1 vial as negative control. 2. Pipette 60 microliter of standard A, B, C, D, and E into vials. 3. Pipette 20 microliter of control into 1 vial. 4. Pipette 20 microliter of serum samples into vials. 5. Add 40 microliter of treatment solution into vials with control and samples. 6. Place the plate in the reader. Incubate it at 37 degrees for 10 minutes. Shake the plate for 10 seconds. Note: Here we did standards, controls, and samples all in single. Customers could do duplicate according to their requirement. Step 4. Main reagent preparation. 1. It is recommended to resolve the main reagent during the incubation of samples. 2. Take out 1 vial of main reagent R1 and reconstitution solution R7. Open the vials slowly without touching the inside of the rubber cap. 3. Add 1.3 ml reconstitution solution R7 and dilute R6 into main reagent R1, respectively. Add R7 before R6. Do not touch the inside of the rubber cap during the operation. 4. Gently mixed. Do not vortex. Note: 1 vial of main reagent R1 is enough for 24 vials. If the test needs more than 24 vials in a run, then mix all vials of main reagent into 1 vial before addition. Step 5. Addition of main reagent. 1. Take out the plate from the reader after 10 minutes. 2. Add 100 microliter of resolved main reagent into each vial. Step 6. Reading. Read OD per minute value at 37 degree kinetically at 405 nanometer and 490 nanometer for 40 minutes. Send report after 40 minutes. Thank you for watching.
The third assay we're going to show you is the Fujifilm Wako procedure.
Fujifilm Wako presents a fast, simple and efficient test for the early detection of invasive fungal infection. The assay is based on a turbidimetric test, determining the levels of Beta-D-glucan, a component of the cell wall of most fungi, direct from patient specimens. In just a few simple steps, the toxinometer provides you with a quick and clear in vitro diagnostic for the quantitative determination of beta-glucan in serum or plasma. When setting up the platform, please avoid positioning in direct sunlight and avoid potential vibration from the operation of nearby lab equipment. Switch on the toxinometer and thermostation. Ensure the thermostation has reached the required temperature before proceeding with the pre-treatment protocol. If a new reagent lot of R2-LAL reagent is being used, please calibrate by scanning the calibration card. Enter the patient sample IDs using the touchscreen or barcode reader. For sample pre-treatment, please prepare the reagent tubes by decapping and covering with aluminium caps. We recommend adopting the reverse pipetting technique for liquid handling throughout. Transfer 100 microliters of your serum or plasma sample to the pre-treatment solution tube and mix well. Incubate the sample in the thermostation at 70 degrees Celsius for 10 minutes. Subsequently, cool the sample in a cooling station for at least 3 minutes. For the measurement step, transfer the pre-treated sample to an LAL reagent tube and mix it gently. Please check for air bubbles in the liquid. Set the tube in the toxinometer. The turbidity change caused by the gelation reaction is detected as a transmittance change. Results are calculated quickly and reliably in less than 90 minutes. Quantitative results are printed out automatically and transferred to LIMS. For QC, LAL positive control is available. For preparation of the positive and negative control and their subsequent measurement, please refer to the respective product inserts. In the case of samples with beta-glucan concentrations above 600 picogram per microliter, a dilution buffer is available. When measurement is complete, the analyzer can be shut down by selecting the Quit command on the touchscreen display. Once the screen has turned black, please wait for 30 seconds before switching off the analyzer. Fujifilm. Value from innovation.
The fourth assay that we'll show you today is the Aerobiology Gold stream assay. So here you have the box with all the reagents in it. Take time to familiarize yourself with all of the reagents and the instructions for use in particular, and these should be read carefully. Identify the solution A and B, and there should also be a clear unlabeled vial associated with these two solutions. It's important to mix solution A and B in a ratio of 1:1 in the mixing bottle. So use a pipetta, which should be glucan-free and used for this purpose, and glucan-free tips, if you possibly can, to set this mix up. Remove the required amounts from solution A, place in the mixing bottle, and then do the same for solution B. Close the lid, and then this mixed preparation of A and B needs to be vortexed thoroughly to ensure that it's fully mixed. And label the solution so you know which one this is, because this vial looks similar to the standard curve bottles. Then open the plate, removing it from its plastic wrapping. Do not touch the bottom of the plate, and orientate the plate so that you can then set up these samples and standards as shown in this grid. The first set to be set up are the samples, and first you use 20 microliters of this premixed solution into the sample area only. And then 5 microliters of each sample is placed into the same wells. Clearly the accuracy of this pipetting is important, and a glucan-free pipette and pipette tip are important as well. Usually these are done in duplicate, but this isn't absolutely necessary. Ensure that you've labelled which sample goes into which well so that you can interpret the results correctly when the assay is complete. The plate with its cover on it should then be placed into the microplate reader at 37 degrees for 10 minutes to warm the plate up. And in the meantime, you then have to prepare the standard solutions. So you dissolve the glucan standard with the diluent, and this is important to get the concentration correct, because this is the primary concentration which is used to prepare all the lower concentrations. This should then be thoroughly mixed, vortex for at least 30 seconds to ensure that there's complete mixing. Then a set volume is pipetted into each of the lower concentration vials, and these are kept in sequence to ensure that you know which one is which. And subsequently, an equal volume of the standard is pipetted from one to the next to produce the dilution series. Then remove the ELISA plate from the reader and set up your standard curves. This is done in duplicate, and the high concentration is pipetted into a pair of wells. The pipette tip is discarded before the next concentration down is used, and this should be completed until all of the standard curve wells have been added to. Then it's important to take the reconstitution buffer and this is mixed to produce enough reagent for all of the assay. It's important when you're holding the lid of this reagent buffer not to touch the inside of the lid. And you gently mix this to ensure mixing. Obviously, you don't want any extraneous glucan added to the assay at this stage. Then this main reagent is then added to all of the wells at a volume of 100 microliters. You start with the samples. And move to the standards afterwards. When you do the standards, you start at the lowest concentration first and then move up to avoid any possibility of carryover of high concentrations of glucan into the lower concentration wells. You then take the lid off the ELISA reader and place it in the reader and set the experiment going. The instructions for interpretation and interpretation of the standard curve in particular are in the IFU. So the greatest value of the BDG assay is in its utility in excluding most fungal infections, particularly invasive candidiasis and intra-abdominal candidiasis or peritoneal candidiasis. It's also of real value in supporting a diagnosis of pneumocystis pneumonia when PCR for pneumocystis is not available, and particularly in the non-HIV patient when atypical features are quite common. So when the laboratory reports a BDG, both the value should be reported as well as the interpretation. Different tests have different cutoffs, and there have been suggestions in the literature about different cutoffs. And I'm not going to address the precision of those cutoffs today, but assume that you would be using the manufacturer's cutoff unless you have a good reason not to. If the BDG result is elevated, then the text report should read, if you have enough space in your reporting system to provide it, elevated BDG consistent with a systemic or pulmonary invasive fungal infection. Send a second specimen to confirm. If the BDG is not elevated, the text report should read invasive fungal infection very unlikely. It doesn't absolutely exclude it, as I will show you. On a second positive specimen, the text should read second elevated BDG likely to represent a systemic or pulmonary invasive fungal infection. So in order to be able to report this, the laboratory staff will need to look up and see whether a previous specimen has been run on that patient. So overall, a rising glucan level, or OD, is suggestive of progressive infection, but the OD values can't be used to monitor therapy successfully, although persistently high levels over many weeks may indicate the need for continued therapy, although this is by no means certain. Common reasons for a positive result without a fungal infection are as follows. Abdominal surgery patients soon after surgery, and this is related probably to gauze used during the surgical procedure. Sometimes a blood bottle contains glucan, and that can give a false positive result. Patients on hemodialysis, on hemofilters or other circuits used in ICU is a common reason for a false positive BDG. Patients who have a blood transfusion or immunoglobulin infusion may have a positive BDG, which is not clinically important. And patients with sepsis and mucositis generally have a leaky gut, and that allows translocation of BDG from the GI tract into the bloodstream, but doesn't always represent invasive infection. So first I'll address invasive candidiasis, and I'm going to show you various studies to illustrate the statements that I've made about how to report the result. So this study, published in 2011, was a prospective single-center study and observational. 95 patients with sepsis were identified, and of those, 14 had invasive candidiasis, and 13 of those a positive blood culture for Candida. So the BDG negative predictive value was 98.7%. So if you have a negative result in this context, it's very unlikely to be invasive candidiasis. And you can see that they used in this particular assay a cutoff of 80 picograms per ml, because this test is a very sensitive test, as you know, with a sensitivity of 92.9% and a specificity of 93.7%. And that was superior to the colonization score and the colonization index. In this study from Switzerland, the authors looked at intra-abdominal candidiasis, and they found 89 patients out of 434 who were at high risk of this. And of those, 27 had intra-abdominal candidiasis, and only 2 had a positive blood culture. So the Beta-D-glucan on one occasion had a sensitivity of 0.83, but a low specificity of 0.4. And the 2 positive tests gave a sensitivity which was slightly lower at 0.65, but a higher specificity of 0.78. And what's important about this study is that the tests that were positive some days before the disease was clinically manifest. So this was an early marker in those who had a positive test. In this study from Pittsburgh, Hong Nguyen and colleagues looked at 55 patients with invasive candidiasis, many of whom had intra-abdominal candidiasis, and 73 at-risk controls. The blood cultures were only positive in 40% of patients, but the BDG result was positive in 56% of patients, and they had an in-house PCR that they used, and that gave a positive of 80%. So the BDG was superior to blood culture, and combinations of tests, particularly PCR and Beta-D-glucan, were helpful. There's been a little bit of work on BDG for neonatal sepsis, partly because of the need to diagnose invasive candidiasis early. And as you know, this disease is particularly caused by Candida albicans or Candida parapsilosis, and the overall sensitivity was greater for albicans than parapsilosis. The sensitivity was 89%, specificity was 60%, so not as specific and not as good at excluding the diagnosis in this group of patients. Now, with regard to Pneumocystis pneumonia, this meta-analysis, which used different methods of measuring Beta-D-glucan, found 3 studies in HIV-positive patients. They diagnosed a case as having microscopy positive with a positive imaging, and probable cases of Pneumocystis PCR with consistent imaging. And you can see that the sensitivity of the BDG was pretty good at 0.92, slightly better in HIV than non-HIV, and in non-HIV it was 0.85. And the specificity was similar, 0.78 in HIV and 0.73 in non-HIV patients. So while not a perfect test, this is a helpful test in supporting the diagnosis of Pneumocystis pneumonia. I should note that there's very few data published in children with pneumocystis. So in New York, this retrospective evaluation of the value of Beta-D-glucan was particularly that they found that a negative test had a high negative predictive value for patients not having pneumocystis pneumonia. And that was helpful because it meant that the doctors could stop what is often toxic therapy for pneumocystis pneumonia. And in the patients who had a positive pneumocystis PCR in their BAL and a strongly positive BTDG, this combination of tests was 100% sensitive and specific for PCP. And as I'm sure you also know, that a raised LDH, that is lactate dehydrogenase, and ground glass changes on the CT scan were also valuable in supporting a diagnosis of pneumocystis pneumonia if patients have only one of PCR or a lower level of BDG positive. In invasive aspergillosis, the recommendation in the recently published guidelines from the ESCMID and ERS and the ECMM recommended a B2 recommendation for Beta-D-glucan alone for invasive aspergillosis, but it was recognised that if it was positive in combination with a PCR or galactomannan, that was more likely to represent real invasive disease. Another meta-analysis published a few years ago now showed overall a BTGG sensitivity of 77% and specificity 89%, which was similar to the galactomannan and Aspergillus PCR assays. However, there are false negative tests in profound neutropenia, and the BDG assays that were included here were not per sample assays but per patient assays, and many patients have multiple assays. And one of the reasons for this is that if there's no damage to Aspergillus hyphae with monocytes or macrophages or neutrophils or platelets, then there's very little release of BDG into the bloodstream. BDG is not a very helpful test for chronic pulmonary aspergillosis. In this study from 2 studies from Japan, they found a sensitivity of 19 to 27% only. And you can see the results on the right in terms of the cutoffs that they used. Now, other people have used different sample types for measuring BDG because the typical sample is a serum sample. This study looked at bronchoalveolar lavage fluid. Again, it was a meta-analysis, quite a lot of patients, and essentially it was an unhelpful test. The sensitivity was 0.52 in the upper panel and a specificity of 0.58, and that's only slightly better than random. BDG has also been used in patients with cryptococcal meningitis, and as you know, there's not very much BDG is produced by Cryptococcus. Nonetheless, in this study from Uganda, the 109 sera would usually had a positive result with a sensitivity of 0.79, but a lower specificity of 0.61, which you'd expect because these patients have usually multiple other factors and sometimes have pneumocystis pneumonia or other disease alongside cryptococcal disease. But the CSF was also positive, which was interesting, slightly higher sensitivity and specificity. And what was also remarkable is that the levels fell off in these patients as they were successfully treated in the CSF, but it didn't change as fast in the serum. There's a small number of patients in this study, but nonetheless the trend is obvious. So how do you use this test in the routine hospital? So the first thing to say is that most of the assays that are available require you to run multiple specimens at the same time to make commercial sense and in terms of the workload for the laboratory. The exception to that is the new Fujifilm Wako assay, which is a single specimen machine, and you can put single samples in and have them run as they arrive in the laboratory. And that may be useful when the test is not requested very often, but it's important when it is requested. A negative BDG usually allows antifungal therapy to be stopped, particularly in the intensive care unit, and that saves quite a lot of money on antifungal therapy. And therefore, every day that passes when unnecessary antifungal therapy is given costs quite a lot of money. So if rapid turnaround times can be achieved, they are cost effective if multiple specimens are run together. And here's an example from our hospital where BDG was run every day during the week. They did a 4-month audit of these samples and the patients for whom they were sent. They're admitted to the 2 ICUs, and these are patients started on micafungin for suspected or proven candidemia. In fact, only 16% of these patients had Candida isolated from blood. 2 of those were ECMO patients who have a higher risk and rate of candidemia. And 38 cases had negative blood cultures, and the Beta-D-G was negative in 21 of those cases, and micafungin was usually discontinued in those patients, so 19 out of 21 had their antifungal stopped. And during the study period, there were no deaths due to candidemia, and the monthly antifungal expenditure reduced substantially. And by running this test in that setting for the ICU, other patient groups in the hospital with a much lower frequency of Candida could have a rapid turnaround, which was helpful across the hospital. So in conclusion, in patients at risk of invasive candidiasis, a negative BDG usually rules out infection. Positive results should be repeated for confirmation, as single positive results may be due to many causes, particularly in post-surgical patients and complex ICU patients. In patients with possible pneumocystis pneumonia, a high level is very suggestive of pneumocystis pneumonia. In cryptococcal meningitis, mucormycosis, and invasive aspergillosis, a negative BGG cannot rule out the infection. Although it does make it less likely, it isn't good enough to exclude infection on that basis. And if a daily BDG service can be run, associated with education of clinicians and antifungal stewardship, then quite a lot of savings can be made and a more focused antifungal therapy given to the patients who really need it. And that service can then support the rapid diagnosis of fungal infections across the whole hospital. There are a number of references here which you can link in to help in terms of reading up about this subsequently.
Right, many thanks, David. Very exhaustive, thorough coverage of this important assay. Quite a lot of questions are coming through all the time as you were speaking. We also have a panel of questions here, but let me start off with a question that a number of people are asking and have asked recently. A lot of the people who are attending, listening into this webinar, are from countries which can't necessarily afford the equipment and the reagents and so on to perform this test, but they're also convinced that it's very useful. Any information, any recent information on where are we, if possible, with a lateral flow device for fungal glucan?
So that's an interesting question. We discussed this in Kampala at our Central Diagnostics meeting about 2 years ago, and one of the key Japanese inventors of the original glucan assay was there. It's probably very difficult to do a lateral flow assay for several reasons. One of you is that you're dealing with extremely small amounts of glucan. Secondly, you've got an open assay in the sense that the cassette and the filter paper is, while it may be sealed initially when it's manufactured, it's then opened to the air. And we know that glucan is present in a lot of dust and other external environments. And the actual paper that's used within the lateral flow assay may not be glucan-free. So I don't think we're going to see a glucan LFA in the foreseeable future. I think it's going to require a different sort of technology to have a rapid single-use assay.
Okay, and again, questions which reflect where the attendees are working. What about histoplasmosis? Is this test useful at all in the diagnosis of histoplasmosis? And the questioner here specifically asks about African histoplasmosis, either for diagnosis or monitoring therapy.
There's very few data for BDG and histo. There's a recent meta-analysis from the US where they looked at ATS recommendations for management of patients with fungal infections, and they concluded that there wasn't enough data to make a recommendation. There's also a recent paper on CNS histoplasmosis, and it is possible to detect a small amount of BDG in the spinal fluid of patients with the rare form of histoplasmosis in the CSF, but it is only just above the cutoff. So my suspicion is that the lack of data, given that the US has been using glucan for over a decade, suggests that it isn't a very useful assay. Otherwise, somebody would probably have written it up. But overall, there's just not much data.
And then leading on from that, you obviously mentioned the restrictions in how this test can be used for detecting and diagnosing mucormycosis. But there's a question here, what is the sensitivity and specificity of BDG to diagnose mucormycosis? You may just want to expand on that a bit. We know, of course, that you have covered this topic a little bit.
There's very little Beta-D-glucan in the cell wall of mucorales, so I would expect this assay to be really almost useless in that context. However, there are patients, immunocompromised patients with dual infections or even triple infections. So an older study from the MD Anderson suggested that about 20% of their patients with mold infections had dual infections. So if you had a patient with a Beta-D-glucan and you had an indication that that patient did have mucormycosis from microscopy or histology, then that might well suggest that you actually have a dual infection. So I think it isn't useful for mucorales. And so a patient, for example, neutropenic patient or other patient with the radiological features which look like invasive aspergillosis, but the glucan is negative and the galactomannan is negative, is highly suspicious of mucormycosis.
Okay, so another question. From your own experience and from the experience of the National Aspergillosis Centre, is there any particular pattern within a CPA patient, for example, an aspergilloma, where there's quite a high, large fungal biomass, where you would expect the patient to be BGD positive, their serum to be positive for BDG?
I don't know the answer to that question. My suspicion is no. We've done, and Malcolm, you know this, very few BDGs in these patients. In the number that we have done, they've always been negative. I think the fungus in the cavity of the lung is pretty sequestered and not much leaks into the bloodstream. And I suspect that's the reason why it's typically negative. And I don't know why some patients are positive and some are negative. It's possible that that represents a more rapidly progressive disease, but I don't think we've got the data to show that.
What about neonates? Of course, there is a prevalence of systemic Candida infection in low birth weight neonates. What does the literature tell us about the usefulness of this particular test in that patient population?
So I presented one study of that, and essentially it is detectable, and many of these babies with candidemia or disseminated candidiasis do have a positive glucan, but it's not particularly good with a sensitivity specificity of around 70% and 80%. So I think it cannot be relied upon to rule the diagnosis in or out, but it may be helpful if it's impossible to get blood culture or there's some other technical problem with acquiring blood from the baby.
Yes, there is this paper, isn't there, that came out in Medical Mycology back in 2018, looking at neonates. And really confirming what you've said, the sensitivity, specificity, not fantastic, but they set their own cutoff at 106 picograms per mil, which is higher than the cutoff that we use, for example, the Associates of Cape Cod test. But their conclusion was that the levels decreased with antifungal treatment, and the test was able to detect glucan in cerebral spinal fluid. But as with a lot of these studies, a lot of unanswered questions. And that leads us on to another question. How useful is this test for candidemia caused by non-albicans species?
Beta-D-glucan is found in virtually all the Candida species, as far as I know. I haven't personally seen data, but you might know, Malcolm, on Candida auris, which is a little bit distant from some of the other species, as is Candida glabrata. But as far as I know, Beta-D-G is present in all species of Candida and in cases of candidemia. Whether the precisely the same sensitivity specificity applies to every species, I think, has not been described in much detail. But the main species of albicans tropicalis, parapsilosis, definitely, these are usually positive.
Okay, so another question that's just come through. Can fungal blood culture replace glucan detection in the absence of the former?
In candidemia, there have been several studies, autopsy and other means of approaching the diagnosis, like the one from Pittsburgh that I showed you, which all indicate that the sensitivity of blood culture for invasive candidiasis is about 40%. Now, higher volume blood cultures increase that yield. Patients on fluconazole or other antifungal therapy decreases the yield, particularly for Candida albicans. That's from a very large Japanese autopsy study. So there are factors which improve or decrease the sensitivity of blood culture, but overall it's about 40%. Beta-D-glucan is better than that. In the study from Pittsburgh, it was about 60%, and PCR was around 80%. So I see these as complementary tests. The problem with Beta-D-G is you do have false positives related to swabs and blood bottles which contain BDG, so it's better to have a second sample to be sure of the answer. And it doesn't tell you what the species is or the susceptibility of the organism is if it's positive. So you then have to make a judgment about which antifungal to use, and you don't have that guidance. So that's how I would do it. So I don't think there is a replacement. I think it's a supplementary investigation.
So here's an interesting question. I'm sure lots of labs agonize over this particular issue. What would be your advice for lab personnel in reporting results of suspected invasive fungal infection when using this test? Should the clinical diagnosis be a guide in our reporting?
That's an interesting question. I think a dialogue with the clinician is a good idea. I think that's always a good idea when you're dealing with an invasive fungal infection, because most clinicians don't feel comfortable with the whole management of these patients. Obviously, if you've got a pneumocystis case, then a positive PCR is a very helpful, and they're often very high, the Beta-G levels, very, very high in those patients. What's more difficult is if you have a sort of very multi-morbid ICU or critically ill patient, where there's a possibility of both Aspergillus and Candida and some immunosuppression and surgery, then interpretation and guidance in that context can be much harder. Therefore, writing a simple report from the lab to cover all the circumstances is pretty tricky. And that's why I think it's important to represent, both give the value and the fact that you want to do a second assay. But as I've shown you, with a sensitivity of around 75% for invasive aspergillosis, you may report this assay is highly unlikely to represent invasive aspergillosis. You've got a 1 in 5 chance of being wrong. So maybe highly likely or highly unlikely is overstating it. So I don't think I would take too much credence on the clinical information in my reporting, actually, because I think it's quite difficult.
Yes, and of course, our own experiences, and at the moment we're doing 3 to 4 glucan associates of Cape Cod Fungitel glucan runs per day, 4 plates, with very little clinical information accompanying the request. Of course, in an ideal world, it'd be very nice to follow up the very high values, and we've had quite a few of those, but time doesn't permit to interrogate to find the requesting clinician and discuss the case further. That is a frustration of the setup here in Manchester. There's been a lot of interest, hasn't there, over the years, and I think the companies have obviously taken this on board to a certain extent, where a single sample can be tested, as opposed to filling the whole template, the whole plate, just to reduce the costs. But I just noticed the other day there's a paper now from Associates of Cape Cod where the Fungitel test is now available. It's called Fungitel Stat, and this is for single samples. So it's going to be interesting once we are able to get our hands on this, how it's going to perform. But the actual performance data, comparative performance data, looks in the paper, which came out in an issue of Medical Mycology very recently this year. It'd be quite interesting to see how that performs in a routine setting. Right, let's see. Yeah, there are a lot of papers on COVID with co-infections caused by Aspergillus, and you've seen these, and we alluded to these in the webinar recently on galactomannan. Do you see any value of this particular test in helping this particular diagnosis of what's been called putative aspergillosis?
I think the answer is yes, because sometimes the patients with COVID are so sick, it's not possible to get a respiratory sample. Sometimes you can when they have sort of standard physiotherapy aspiration of their airways to prevent too much accumulation of mucus, but doing a proper bronchoscopy, even a fast one, is often too difficult because of their oxygen requirements, in which case a Beta-D-glucan may well be helpful. However, we really don't have any idea what the performance of that is. We think that invasive aspergillosis complicates critically ill COVID patients somewhere in around 1 in 5 to 1 in 3 of these patients, usually in the second or third week of their ICU stay. So repetitive monitoring and a change in the Beta-D-glucan may be quite a helpful approach to this problem, but we do need more data. It's going to be difficult to always validate the answer as well, which is another tricky part.
And just let the people listening in to this webinar, there's a very useful, and it's updated very regularly, list of papers on the Life Worldwide website about co-infections fungal co-infections in COVID patients. Okay, you sort of anticipate that your patient is going to have a false positive result in this test. For example, as you've mentioned, the glucan-containing gauzes and the dialysis membranes, or possibly the reverse, a false negative because they're neutropenic. Would you still send off a request for this test, or would you choose a different type of test?
The BDG isn't probably so useful in profound neutropenia. And I think a Beta-D-glucan is more useful. But if you've got a patient who's got some neutrophils, non-steroids, and a sort of a different form of immunosuppression, then I think it may be quite a useful assay. It's not going to be a perfect assay, so it needs to be taken in the round with all of the other information available on the patient, such as their imaging, the level of immunosuppression, other biomarkers and cultures, and so I think this is a fairly sophisticated judgment about what the answer may mean in those patients.
Okay, I think we've had a fantastic range of questions here. Apologies for the challenging nature of some of these, but I think they are obviously real questions that people are asking, and they're concerned about possibly even using this test. But as we've heard, not everybody has access to everything that's needed and the laboratory environment that's needed for running this test. So thank you very much, David, and thank you very much to everybody who's been tuning in to listen to this second Life Worldwide webinar. Thank you very much.
Thank you very much for your attention. There are various other resources that you can access, including on the Life website and YouTube, multiple other videos which would may be helpful to you, and also a microscopy course that may be valuable for you. Many thanks.